Kia ora everyone, welcome to this Goodfellow Unit Webinar on menopause and primary care, myths and misconceptions, and restoring confidence in primary care of managing menopause with menopausal hormone therapy. Now I'd like to introduce our expert speaker tonight. It's Dr. Stella Milsom. Stella is a reproductive endocrinologist working at Auckland Hospital and Fertility Associates. She's also on the board of Osteoporosis New Zealand and is chairman of the endocrinology training in New Zealand for the College of Physicians. Welcome, Stella.
Thank you.
Now I'd like to start. Let's go ahead with our menopause webinar.
Well, good evening, everyone, and thank you very much for taking the time to attend and listen in. Tonight's very basic. It's about trying to restore confidence in menopause prescribing so that the bulk of this is done in primary care rather than either not being done at all or referring to a specialist. Now, there we go. Yes, just my disclosures. I think they're reasonably straightforward. And I thought we just might define the various time course over menopause so everyone knows what we're talking about. Now, early or premature menopause, we've got a slightly more PC name now. It's called premature ovarian insufficiency, or POI, but any of those terminologies will do. That really means last period before the age of 40, and it's actually surprisingly common. It's at least 1% of women. And if you then add in all the women who perhaps have had a surgical menopause, had chemotherapy or radiotherapy, that figure may be as much as 8% of women. So it behoves us all to know about it. That is clearly a case where women would be referred to a specialist. There might be unusual causes, as often associated diseases, so that does require more of a workup. I'd make the comment that although it's still relatively uncommon, particularly in the younger women, it isn't particularly well diagnosed in primary care, and it's not difficult to diagnose. If a girl or a woman hasn't had a period for 3 months or more, if her FSH is raised on 2 occasions, you have the diagnosis. So it's not a tricky diagnosis, but very important to consider it. Now, early menopause, there's often a bit of overlap here, people not quite sure what to call premature and what to call early. Early is between 40 and 45 when you have your last menstrual period, and that's about 5% of women. So after 45 is absolutely fine. That is normal years of menopause, and some women will not become menopausal till they're nearly 60. So we call the perimenopause when the menstrual cycle started to get irregular, and when you've actually finally done with periods, and often that's a look back and see, then you've actually into the post-menopausal time. And of course, if you want to know what's happening with the hormones, you've got estrogen levels falling, that's the reason for all the symptoms, and FSH starts to rise. Now, it's important to understand the symptoms. These symptoms can really be very severe. So 1 in 4 women will have awful symptoms. It will really bring women who are high-powered women almost to their knees with miserable symptoms. And the symptoms that really upset women are probably the vasomotor symptoms the most. The hot flushes, which might be occurring every hour, and of course the hot flushes at night, the sweats, which are disturbing sleep. Sleep might be impaired just on its own, even without flushes. There's something happens when the estrogen levels go down that affects sleep. There are often mood changes. There can be crawly, itchy skin, joint pains, irritability, tiredness. So symptoms can vary. In the early stages of the menopause, it might be more around mood and nostalgia, bloating. Perhaps headaches might start. And of course, the signal is that the periods are becoming more and more irregular. Later on in the menopause, while the vasomotor symptoms might well persist, then symptoms such as vaginal dryness or the urogenital symptoms might become more prevalent, and it's important to ask women about those. And obviously, estrogen deficiency long-term has a serious effect on our bones, on our brain, and of course on our cardiovascular system. Really important that we understand that these symptoms aren't transient. They can be a variety of patterns. They might start and gradually get worse. They might be a roller coaster where they're severe, appear to ease off, come back again. But the mean duration of symptoms is actually 8 years. So these aren't transient symptoms. These are symptoms that seriously affect quality of life. In fact, it's said that the effect on quality of life is as bad as losing your house. So important not to dismiss or minimize these symptoms. Couple of other things that are really important. Some women are going to keep on having symptoms even into their 60s and 70s. So again, that 15 or 20% of women that are still flushing even into later life need to be considered and managed. So if you take women in general, 1 out of 4 women will have very few or no symptoms. It won't be an issue. 1 out of 4 women, or 25%, will have awful symptoms, and perhaps 50% of women are going to be somewhere in the middle, and their perception of their symptoms and the effect on their general quality of life is probably going to vary depending on what else is going on in their life. I think you'll have all seen the 7 dwarves of menopause, but that little cartoon does describe it pretty well. Itchy, bitchy, sweaty, bloaty, sleepy, forgetful, and a psycho. But remember, it can be managed. Now, let's start with our first case, which illustrates, I think, a lot of the major points that are going to influence the way we manage this in general practice or as a specialist. So here we have Annette. She's 48. She's married. She's finished with her family. She's well. She's still got a uterus. She's slim, and she notices that her periods have become irregular for 12 months. She comes into the surgery because she can't sleep because of hot sweats and flushes at night, and she's also flushing during the day, which is making it very difficult when she's a real estate agent and trying to look professional. So without the sleep, she's not functioning well, her mood is getting down, and what she says to you as her primary care doctor is, I can't work, doctor, please do something for me. Now, this is not uncommon at all. I would see this every week, sometimes every day in my practice. Now, this is, in fact, a real life case. I'm not exaggerating. This is actually what's happening up in primary care, which is why this is such an important topic. So her trusted and usual general practitioner says, don't worry, Annette, you're just the same age as me. We're just getting older. She's not happy with that. She goes and sees another doctor in the practice who says, well, don't worry, Annette, you won't feel like this for very long. Why don't you just take a bit of time off, take things a little bit easier? Still not feeling very comfortable with his advice, goes to see a GP in another practice who suggests a prescription for an antidepressant. Okay, now, Annette is healthy. She's a midlife woman. She's got absolutely barn-door clinical menopausal symptoms. It's pretty hard to think of anything else that might be going on. So why is she getting advice that isn't dealing with the primary problem? Why have no evidence-based options for managing her symptoms been discussed with her? And this is a woman who's an absolutely ideal candidate for the most effective management strategy that we have, which is, of course, menopausal hormones. Now, you notice I use the terminology menopausal hormones. Again, just a slight change in terminology from HRT. So we now, if we want to be PC, refer to MHT. So she's an ideal candidate. She'll feel a great deal better. Why is this not first-line therapy? Now, to understand what's been happening in the last, it's more than a decade, probably 15 years, we have to look back at the timeline of what's been happening with menopausal hormones, particularly a study which was published in 2002 called the WHI trial. So even before we get to that, we've known since the 60s, so we've known for 60 years, that estrogen really makes a difference, a positive difference to these menopausal symptoms. That's the missing hormone, and that's what needs to be replaced. By the 70s, we realized that just estrogen alone, if you had a uterus, you got an unwanted side effect, which was you got endometrial hyperplasia or cancer. So you needed to add a progestin into the regime. And really, that's the only reason to add the progestin into the regime, is to mitigate this risk of endometrial thickening, endometrial hyperplasia. We get to the 90s, we have a long-term cohort study, the Nurses' Health Study, and not only do we realize that estrogen is good for the immediate symptoms of menopause, but it seems to reduce heart disease and osteoporosis. So it's now looking like a wonder drug. All right, we move on. And we have our first randomized trial, and by this time in 2002, we're understanding the importance of randomized data. So the WHI trial published then, and I think I just need to take you through a little bit about the problems with this trial. This was a trial designed to really understand the potential preventative effects of giving estrogen to older women in the hope that they wouldn't die of heart disease. You're all aware that although women think they're going to die of breast cancer when they're postmenopausal, the major cause of death is heart disease. So here we thought we had another option in terms of preventative strategies. And in 2002, when the trial was published, it was said that it was discontinued because of safety concerns. A couple of years later, the women who just got estrogen, who'd had hysterectomy, so didn't need a progestin, had their data published. It was very positive data. It got no publicity. And we've had really a decade, 15 years, that women have not been prescribed menopausal hormone since that time because of the way this trial was publicized. Now, without going into too many details, this could never be published in this format in 2018. It could almost be considered fake news if we were going to refer to Donald Trump terminology. What happened is it was a big multi-center trial in the States. A very small group, in fact a management group, adjudicated results. They didn't consult with all the investigators. They wrote up a paper. It went to the media. When the other investigators who were involved in the trial heard about it, tried to prevent it, it was already in the warehouse about to be sent out to the subscribers of the Journal of the American Medical Association. And what was reported was relative risk. And not surprisingly, primary care were just terrified about what they're doing for their patients, and of course women were terrified. If you hear that there's 29% more heart attacks, 26% more breast cancers, and 41% more strokes if you take estrogen and progesterone, of course you're not going to take this medication, however miserable your symptoms are. In fact, and you see in bold, there were actually only 2 significant findings from this study, and that was that there were less fractures, so that was a very important positive finding. I don't think we heard anything about that. And there was an increase in blood clot risk, which in fact is probably true and persists. There was actually no statistical increase in breast cancer events, either the nominal statistics or the adjudicated statistics. And yet, as you saw, that's how it was presented, that this was a terrible agent in terms of breast cancer, but also the heart and in terms of strokes. Now, since 2002, we've had a complete reappraisal of this data. We've also had a lot of extension studies. We've had a lot more data published. And I would say to you as primary care doctors that it behoves you to know that data. It is not acceptable to still be quoting the 2002 paper, which was so misleading. So if you're not up to date, here's your chance, and there's plenty of reading and information sites that you can just spend a little bit of time considering this data. But what we know in 2018 is, first of all, menopausal hormones are the most effective treatment of the vasomotor symptoms, the most troublesome symptoms of menopause. Secondly, we know that if we are prescribing them for the women who are the group of women who get these symptoms, these are the women in their 40s and 50s who are perimenopausal or immediately postmenopausal. The women in the WHI trial were older women, and they couldn't even go in the trial if they had symptoms. So they're a completely different group of women receiving a different set of hormones. And I've listed there, if you and you can come back to that, that the risks that were touted as being so important are essentially rare, minimal, or not at all. So the breast cancer risk, even if there is a risk, it's extremely small. It's classified in the rare degree of risk, one additional event per 1,200 women treated per year. So an extremely small risk, and that is the women who have to have a progestin. If you have a woman who's had a hysterectomy, her breast cancer risk is not increased at all, or in fact, maybe even less. None of that data seems to have percolated its way through to either the general public or, in fact, to many prescribers. Stroke risk is minimal, not increased in the younger women, not increased with transdermal estrogen, and a very small increase otherwise with oral estrogen and progesterone in the older women. Heart disease, essentially tiny or no increase in the combined use, and in fact reduced in the women under 60. So we're almost back to the original hypothesis where if you use menopausal hormones in the right group of women, you may even reduce their risk of heart disease. It's likely that there's a small increase in blood clot risk, VTE risk in the older women, again with oral but not with transdermal estrogen. We also appreciate, and I'm going to come back to this, that if we use different routes of administration, we use different progestins, we consider the dose, we may even take those very small risks down a notch further. And importantly, last year, we had a major paper, again, very little publicity, saying that menopausal hormones do not increase mortality from any type of cancer, from cardiovascular disease, or from stroke. So I think that's very reassuring information to give our patients. And of course, although we haven't got time to talk about premature menopause tonight, anyone who's diagnosed with premature menopause is going to be on hormones until they get to the average age of menopause. Then you can roll back the clock and consider matters again. Now, hopefully feeling somewhat more reassured about whether or not you can discuss menopausal hormones with your patient, we need to think about what we do in the consultation. Now, I think the first thing is that in general practice, with a consultation that's only 10 or 15 minutes, we can't get through everything. So we need to set expectations with the patient that we're going to take 2 or 3 consultations over it. The first visit, take it as an opportunity to do checkups, breast, bone density if appropriate, look at diabetes status, blood pressure, lipids, always check and investigate abnormal bleeding. We need to know about contraception. And patient may want some written information, and the Australian Menopause Society is an excellent site for this. You want your patient to have a think about how they want this managed and take an active role in the discussion. And at the second visit, you've got time to look at their results. Consider their lifestyle. I mean, this is a wonderful opportunity to think about this woman who's going to spend almost half of her life as a postmenopausal woman. What can you do as her primary care physician to make that as healthy as possible? So you need to discuss things like smoking, like alcohol, like weight, like exercise, the amount of calcium she gets in her diet, and make sure that you've set the scene for a very heart-friendly postmenopausal years. And this is the appointment, hopefully, where you can start therapy if a woman wants that. Remember, some women just want education. They need to know what's happening to themselves. And make sure that that decision-making is shared. Now, some do's and don'ts. Just let's go to the bottom don'ts. In general, a woman over 45, you don't need to do hormones. And we're spending an enormous amount of money on doing hormones when we don't need to. And this is crazy as an endocrinologist. Most hormone conditions I manage, we do both check hormones and we manage future care by hormones. This is not one of them. So the only indications perhaps for doing the FSH would be the younger woman, or perhaps a woman who's got a marina in and who's not menstruating and you can't use the menstrual cycle as a guide. Remember, we're not going to use hormones either to guide management. They're going to be clinical management decisions. It's good to take a good history and just bear a thought for possible other symptoms. You don't want to miss someone who's thyrotoxic. It's very important, I think, to know past medical history because it is going to influence who can get what type of treatment, what family history is important, and as I've said, reinforce key preventative health messages. This might be the first time you've met with a woman for some years, and it's a wonderful opportunity to make the most of their health, of these health messages. Okay, we're back to Annette. Now, Annette's quite keen about hormones. She's heard that they work really well, but she's also heard lots of rumours from her book club and her workplace that they cause breast cancer. So you need to know how to counsel her about this. Now, this is a North American Menopause Society, an excellent website. It's ditto with the International Menopause Society websites, and this is their position statement. And as I mentioned, a very rare absolute increase in risk for breast cancer, and only for the women who are actually needing a progestin as well as estrogen. Remember that, in fact, lifestyle factors, if she drinks alcohol at night, if she's overweight and sedentary, that's probably going to increase her breast cancer risk more than giving her hormones.
Can I just interrupt you for one of those questions that have come through, Stella, has been about, is the progesterone causing the risk, not the estrogen, or is it the combination?
A really good question, and it seems to be the progestin that's causing the risk. And the reason that we know that is that in the women in the WHI who got estrogen alone, they had no increase in risk. In fact, they had a non-significant reduction in risk. Mm-hmm. So it's the progestin component. And there may be aspects to that that can lower that risk even further. So if you want to use a natural progesterone, and we have that now available, it's called Utrogestin or micronized progestin, or put a Mirena in, that may be a lower breast cancer risk, even than we've already stated, than if you use a synthetic progesterone such as Proviron or norethisterone. Women who've got a family history aren't precluded from hormones. If a woman's had breast cancer herself, generally we would not recommend systemic hormones, and I'm going to talk a little bit later about other options, or at least refer the patient for specialist advice in that setting. But you've still got the option of using topical vaginal estrogen if appropriate.
There has been a question about breast cancer survivors, those who have had mastectomies or double mastectomies. Does that still convey some risk to them in terms of taking them?
I think we would still prefer not to use MHT in that setting as a general rule, or as a primary care prescriber. One, because you can't be certain that all breast tissue is removed. Secondly, because of the possibility of say an indolent metastasis that is estrogen receptor positive. So tricky, good question, but that would be something that would perhaps be discussed at specialist level if you couldn't find another alternative. Now, let's think about Annette and the indications for menopausal hormones. I mean, we've stated that this is not treatment for as primary prevention. This is treatment for symptoms. So much as women might like to have it as an anti-aging treatment, no, that is not an indication for treatment. The indications for treatment are that the woman has significant menopausal symptoms and that they're impacting on her quality of life. And again, that weighing up of benefits versus any risks depending on her own personal and family history. Remember that the women under 60, this is also potential treatment for osteoporosis, and we haven't got really time to address that, but certainly a woman who's got some menopausal symptoms and a low bone density, I'd certainly be thinking about menopausal hormones in that setting. And we've already discussed the premature menopause. Now, who shouldn't have hormones? Now, when we think about prescribing the birth control pill, which of course is a synthetic estrogen, we've got quite a lot of relative contraindications. So there are fewer here with what is largely natural estrogen. So the contraindications, and perhaps at a specialist level, these might be relative, but I think in primary care, these would be contraindications. So a previous breast cancer or a high-risk endometrial cancer, undiagnosed vaginal bleeding before it's sorted out, if someone's had a stroke, a recent heart attack, or a blood clot episode. Hypertension is not per se a contraindication, but untreated hypertension would be, and if someone had active liver disease. And there are circumstances and conditions where you might be prepared to use hormones, but you prefer to use a transdermal estrogen. And situations like that might be migraine with aura, someone who's got gallbladder disease, someone who's got high triglycerides, someone who's known to have thrombophilia, someone who's very overweight, that sort of thing, where you're trying to, again, bring down any vascular risk even further. Now, Annette's pretty reassured about your discussions of risks and benefit. She wants to use hormones. We now need to know something about how to do hormones. And I think this is, again, an area that people have just basically, because primary care aren't prescribing hormone therapy in general, people have forgotten just how to do it. So just to remind you, the agent, the hormone that's going to be effective is estrogen. It's low estrogen that's causing the symptoms. Estrogen needs to be replaced. If you've got a uterus, you need a progestin to mitigate against endometrial hyperplasia. Okay, so they're the first decisions. Second decision is, if a woman's within 12 months of her last menstrual period, then it's going to be hard to stop periods altogether, so you're probably better to use a cyclical regime or a sequential regime. If she's a year or more post her last period, it's fine to try and have a regime which is continuous, and what you're trying to aim to do is have then no periods, which women rather like. In terms of the estrogen, do you want it funded? Do you want to give it transdermally? Do you want to give it orally? What's the dose you're going to start on? So you've got some decisions around that. In terms of the progestin, you've got to decide if you're going to use a synthetic or a natural progesterone, whether funding matters, so whether you want a fully funded regime or not. And then patient preference. Does a patient want everything in one tablet? Is she prepared to consider 2 tablets? Is she prepared to consider a patch and a tablet? And that brings us on then to familiarising yourself. You don't need to know absolutely every option, but I think some options here that you have, ready to mind and can be discussed. Now, gold standard 2018 hormone therapy, menopausal hormone therapy, would be using transdermal estrogen. And as of last year, we have a funded patch. It's called Estradot. And you can see the doses, anything from 25 to 100 micrograms, tend to start low and then work up according to symptoms. And we now also have natural progesterone capsules, which are called Utrogestin. And unfortunately, they're not completely funded, but they're not a huge cost, about $35 a month. And you can either give that as a cyclical regime or as a continuous regime. So that would be gold standard, and probably most of my starts these days would be that gold standard. Funding may be very important. It may be too difficult to pay for any of this, in which case Proganova, estradiol valerate, is available fully funded, or the Estradot patch, and then you can use a synthetic progesterone such as Prevera. I think most of us probably use Prevera, but norethistone is just as good. And then you've got the women who are not very good at putting several different things on and want it all in one. Again, that is a partly funded option. Try sequins if someone's going to have periods within a year of menopause, or if you think you can ablate the periods, then Cliovant. They're relatively low dose regimes which are very popular. If you don't have a uterus, if she's had a hysterectomy, remember the whole discussion is that much easier. Don't have to worry about breast cancer risk. Don't have to use a progestin, and it's just, does a woman want oral or transdermal estrogen? A couple of things just to make sure women don't stop it, before they've had a trial. So they're not going to gain weight. In fact, if anything, this is going to make it easier to manage weight. So it's one of the urban myths that hormone replacement causes weight gain. There could be a little bit of breast tenderness in the first few weeks, and it usually just settles down, and starting lower dose estrogen will help. Anyone can have bleeding, whatever regime you choose, and most women are quite comfortable, provided you just warn them about it and make sure that they're prepared. I tend to start low dose and just titrate up according to symptom relief. Contraception's important. Now, if the last menstrual period was in a woman who's under 50, we'd probably consider some contraceptive method for 2 years. And if her last menstrual period was only over 50, we'd consider maybe contraception for a further year. Remember that hormone replacement itself is not contraceptive. And back to Annette. Now, she comes back to see you, she's read her information, she's done a mammogram, and that's normal, she's updated with the cervical smear. She says she'd like tablets, and she doesn't want to pay even a part charge, so we start her on Proganova 1 milligram. That can move up to 2 milligrams if she needs it for symptom relief. And because she's been menstruating, we give her a cyclical regime of Provera 10 milligrams for 12 days each month. We then see her in 12 weeks. 12 weeks is a good time to see for review, and Nanette is extremely grateful. She reports that her life is back. And in fact, that would probably be the most common comment after a menopausal hormone start. You check her weight and her blood pressure, they haven't changed. In fact, her weight is slightly better and she's pleased. She's getting regular periods on this regime. She hasn't got breast tenderness. Now, she's been using condoms for contraception, and she's still feeling a bit antsy about the possibility of an unexpected pregnancy. She's only 48, and so a reasonable option is to consider whether she might like to have a Mirena as the progestin component of her regime, in which case she can stop using the cyclical Provera. So that's something to be considered. And then after that, we follow her up at annually. It was recommended 6 monthly follow-up, and that we've got so much confidence in terms of hormones that we put it out to a year unless she had problems.
Yes, we have a flurry of questions, Stella. So there's quite a few questions about the breast risk. One of them has been on benign breast cysts, multiple benign breast cysts found on scans. Is that person likely to be declined MHT, or are they? No. In that situation. The other one was for, I think, someone who has had breast cancer over 10 years ago. History of breast cancer, even if over 10 years, post-treatment and no recurrence, does it mean it's best to avoid MHT forever? Is that them really done?
Look, I think as a general rule, yes. And what one could do is look at the alternatives. It would depend on her symptoms and potentially come back to it. Just come back from the International Menopause meeting, and exactly that question, it's a really good question, was asked by a fellow endocrinologist of the visiting expert.
Is the breast cancer risk still increased when using Mirena for the progesterone component?
Another good question. We think that if you rated it, probably synthetic progestins are probably the highest risk. But again, remember that I've said that risk is very small. Lower risk appears to be Mirena, and lowest risk is natural progesterone. So again, I think it's a conversation you have with the patient, and depending on her individual risk factors and her degree of concern.
The next one relating to that was, should we be counselling young women on the progesterone-only pill about breast cancer? Which is obviously not related to menopause therapy, but is related to the progesterone risk.
That's a really excellent question. I think my answer to that would be, we don't have any data, and we have long-term data about safety of low-dose pills used for contraception. Remember, they are very low dose, and generally what they're doing is affecting the endometrium and the cervical mucus rather than anything else. So they're not as high a dose as that's used in menopausal hormones. But yes, that's an interesting and good question.
There's been lots of questions that have come through about contraception. So obviously the Mirena is available for contraception and a good option.
Yes.
Can you give any advice about oral options for contraception for women on menopause hormone therapy?
What were you thinking of particularly?
It's just, can you give any advice on oral options?
Okay. Well, look, I think that to be fair, the chance of a pregnancy. Let's come back to Annette, who's 48, whose periods are quite irregular, and it is getting very small. It's just not completely zero. And so again, discuss with the patient her degree of concern. So I think that someone who's very concerned, you would think about something like a Mirena. You could, of course, in a healthy woman, continue a birth control pill, and it could be used continuously, so there are no breakthrough symptoms. I mean, if you think of our birth control prescribing, I mean, we used to stop it at 35, and then we stopped it at 40. I would generally be very happy to continue a pill right through till someone's 50 or early 50s, assuming they're not a smoker, assuming they don't have cardiovascular risk, migraine with aura, they're generally healthy, slim and active. And that is also a very good way of managing contraception and PMS. And it's often those women whose husbands had a vasectomy and who then come to attention and suddenly realize how good the combined oral contraceptive was. I mean, you wouldn't need, I guess, if someone wanted Depo-Provera, you'd certainly would have protected the endometrium. So if you did want to use Depo-Provera, then you would just need the estrogen component. In terms of low dose pills, if one is using something like Nor-a-day, you need to use 3 a day at least to get endometrial protection from that very low dose of norethistérone. And we don't have data about Cerazette. So I don't feel totally confident as an endocrinologist that Cerazette per se protects the endometrium. I hope that answers that question.
Yeah, I mean, I think there's lots of questions here about the contraception, and I think that's obviously an issue that people are struggling with. So yeah, it's worth looking into.
I would have thought in general that condoms would be a very reasonable choice, given that there's a low chance of a pregnancy. And if someone wants more certainty or doesn't want the nuisance, then a Mirena is a good thing to discuss.
Would Jadel be another option?
I don't love Jadel because a lot of people get breakthrough bleeding. Yeah, and we don't have evidence that it protects the endometrium, so it isn't something I'd choose in that setting.
Yes. I've had a couple of questions about bioidentical hormones. And
coming to that?
Yeah, it's brilliant. Okay, so that's coming
great.
up,
Yep.
everyone who's asking that. Let me just check through. We've got a whole flurry that has come through. Is there an increased risk of breast cancer? Oh, no, that we've already answered that about the progesterone, which is there a contraindication DMHT with history of migraines? You talked about that. Yeah, before. So.
And in fact, remember that headache and migraine often gets worse as estrogen levels drop. And many women are actually better when they're on treatment. But if you're concerned, if you had a very strong aura, you might choose to use transdermal estrogen. Yeah.
What do you think about topical progesterone cream? Alternative practitioners seem to like this. Do you have
doesn't work.
No.
There's nothing about progesterone given transdermally that gets absorbed into the system. So that, in fact, is if it's being used to mitigate the effect of estrogen on the endometrium, in fact, it's dangerous.
Look, I think some of these we're going to carry on and hear about anyway. So let's carry on for now, and we'll come back to some of the questions that haven't been answered yet.
Might just be.
Sorry, that's me. I've clicked over. There you go.
Now let's get case number 2. I've tried to choose cases which I think are very commonly going to present in general practice. Now, so Shirley's a librarian. She's a non-smoker. She's got good general health, and she went through menopause 14 years ago when she was 50. She got a few flushes. She was in that 25% group that really wasn't too troubled. So she didn't present to you then, but now she has a new partner, and that's lovely for Shirley, but she's got vaginal dryness and intercourse is painful, and she's in fact been too embarrassed to tell anyone about it, but her very sensible, and sorry, this is probably looking very sexist, but her female GP directly questions her about it. What do we do for Shirley? Now, we need to understand that GSM, that's the new trendy name for vaginal atrophy, is extremely common. So it's a symptom of later on in menopause rather than early on, but it doesn't go away unless it's treated. Probably 60% of women who are late in menopause have these symptoms, and it appears that probably a very small proportion of women actually get treatment. So it's a big area out there that is not being recognised and not being treated. In fact, we have very effective means of treating. So she has the vaginal symptoms, but urinary symptoms can also be quite prevalent, and it can be quite difficult to decide between whether someone started to get UTIs or these are the GSM symptoms. Now, options for treatment. We basically come into sort of, if you like, 4 groups. We can use lubricants, and I think women and sometimes practitioners get lubricants and moisturizers a little bit muddled. So lubricants are for intercourse, okay, to just basically lube the system. And a water or silicone-based lubricant is very sensible. And sometimes that's all that's required, and there's lots on internet site, on the Australian Menopause Society, there's lots of things that women out there are using. Now, if more is needed, particularly if there are symptoms that are persistent, are there on a daily basis rather than just with intercourse, you might well want to use a moisturizer. So this is something you're going to prescribe very much as you would prescribe vaginal estrogen. So you have a 2-week lead-in where you use the moisturizer every night for 2 weeks. Doesn't work if you don't use it every day or every night, and then it can be used as maintenance 2 to 3 times a week. And Silk, Astroglide, and Replens are popular. They look like they're very effective. Unfortunately, they're not cheap. It's probably going to cost a woman around about $35 to $50 for a month to 6 weeks of treatment. So it just has to be considered. If the moisturizers don't work, use vaginal estrogen. And you can use vaginal estrogen as long as required. The only option we have in New Zealand at the moment that is funded is Oveston cream, and that's estriol, E3, and again, every night for 2 weeks and then twice weekly. So it has to be used and it has to be persisted with. And there's essentially no systemic absorption, so you don't need a progestin with this regime. And then you'll have a small handful of women who might also need actually to be on menopausal hormones systemically just to get control. If a woman's got a hormone-dependent cancer, we'd go through the lubricants, we'd go through the moisturizers, and we would certainly consider vaginal estrogen, but you'd probably discuss that with her oncologist or endocrinologist if she had an hormone-dependent cancer. And just be a little bit careful if a woman's on letrozole or another aromatase inhibitor. Although the vaginal estrogen, the amount that gets into the circulation is incredibly little and incredibly brief. For aromatase inhibitor using women, we probably don't even want that. So just a word of warning. Now, let's get on to Olive. We got time to do libido issues?
Yeah, as long as we skip relatively quickly.
Okay, so we'll go through this quite quickly. So this is Olive, and she's 47. She's working part-time. She's got 3 teenagers. She's running a house, so she's really busy. She's had irregular periods for 2 years. She's got hot flushes, but the thing that's really bothering her is her libido, which seems to have gone into her boots. And she's, in fact, quite upset that this might affect her relationship. She's in tears when she talks to you about it, having worked herself up to come and discuss it after some months. Now, remember there's many factors which affect the libido. And I think the key thing is that for women, it's not necessarily all about hormones. For men it is, but for women there are many other things. So you need to take a very careful history. Is this lifelong? Is this actually something that seems to relate to the menopause? If it's relating to menopause, it tends to track with the estrogen. And contrary to what we hear from Oprah and various other internet celebrities, it's not all about testosterone.
Yes, there's been quite a bit of that, and I think a few questions have come through specifically on this because it's been in the media. Yeah.
So really important to understand that it's very rarely that it's just the hormones. And I hate to say this as an endocrinologist, but there are many other factors that affect desire and arousal in a woman. So always consider what else is going on in her life, in her relationship, in her psyche. And in terms of strategies, I actually think it's not easy. I mean, if someone comes to me for a consultation, we spend a long time going over these various issues. But basically, just think about managing any discomfort or pain, so any GSM type symptoms. Think about the lifestyle and really get a woman to think about, is she getting any time to her libido? Perhaps manage expectations. So it's perhaps not the lust and enthusiasm that when she was very young, and consider introducing to her the concept of use it or lose it, and considering a little bit of quiet, assigning some time for having intercourse or sexual intimacy with her partner in the same way that she might assign time for her exercise and various other aspects of her life. Systemic estrogens often, but not always helpful. So if it's that she's exhausted and she's tired and she's not sleeping because of flushes, of course estrogen will help. The multidisciplinary approach I find very efficacious. So I think considering use of a psychologist is, especially in difficult to treat low libido, is very helpful. And occasionally we will use testosterone. You'll have seen some very misleading information in various women's magazines and retractions about to be published. But just a very quick comment that In the occasional woman, particularly perhaps a woman who's got surgical menopause, so she has no ovaries at all, we might consider testosterone if systemic menopausal hormones hasn't done the trick and there don't seem to be other issues. The difficulty is getting a formulation of testosterone that's safe and physiological. In our group of endocrinologists, we bring in the testosterone cream, but we don't have a patch available. The implants are no longer available, and we wouldn't use the injectable testosterone that the men are on. So it's a bit tricky. And the bioidentical testosterone is completely unregulated, and you should stay away from that.
Right, I think we should keep going because I think some of these questions we will again be following. I'll keep watching them as they come in, so keep sending them in, but I think we're going to answer them with some of these cases.
Now, let's come on to Kim. Now, Kim's 62, and she's got vasomotor symptoms and isn't sleeping. Her last period was 10 years ago, so she's well into her menopause, and she actually had not only a blood clot, but she had a pulmonary embolus after she broke her femur skiing. So this is a provoked VTE episode, and she's been told in the past she can never take hormones. So for 10 years, she's just been suffering her symptoms, but she's really a bit over all of this. So what can Kim do? And I think we'd all agree with that history, we'd like to avoid using menopausal hormones, or at least first up. That was one of the contraindications. So what do we have that is evidence-based that works? And to be fair, these treatments work modestly, reasonably well. They're not as good as menopausal hormones, but in someone who's had a blood clot, they're probably a safer, at least first-line option. In general practice, clonidine is often used, and remember, we've got a clonidine patch, which the Australians don't have. The other options are an SSRI, and I've just given some suggestions, and there are more suggestions on the Australian Menopause website, and gabapentin. So I think you'd all be reasonably familiar with those. Gabapentin is particularly helpful if the major problem with their vasomotor symptoms is at night. So say sleep and hot flushes are a real problem at night, but they're coping during the day, then a dose of gabapentin, which can be started slowly and titrated up, can be quite sedative and quite useful. If cognitive symptoms, anxiety, low mood are really colouring the vasomotor symptoms, I suspect one would be better to start with an SSRI. So bearing those in mind, and as I say, none of those will have blood clot risk. Increasingly, it's being suggested that we use some of the mind-body techniques, and the one with the most data is cognitive behavioural therapy, but mindfulness is also useful, as is yoga. So just bearing those as options, particularly in combined therapy. Now, after the WHI, we basically opened the door for many alternative treatments to menopausal hormones, and I've listed some of the ones that are out there widely being used, and you can see that many of the widely used options, and you asked me about progesterone cream, remifenin, ginseng, herbs, evening primrose, donquai, etc., absolutely without any evidence or with any safety data for that matter. Minor benefit, we've mentioned some of the mind-body techniques, possibly some soy supplements. Vitamin E helps, but it probably reduces 1 or 2 hot flushes a day, and if you're having 20, that's not of clinical significance. So the effective options we've discussed. Most effective is estrogen, but modestly effective gabapentin, SSRIs, and clonidine. Okay, so I hope that answered the question that came before. And someone asked me about bioidentical hormones. Now, this is a statement from the US Endocrine Society, and there are multiple statements that you could print off to give to your patient so you don't hijack the whole appointment, talking about bioidenticals. So bioidenticals is in fact not even a scientific term, it's a marketing term, but it's terribly persuasive. And with everyone frightened to death about taking menopausal hormones, it's opened the door for people to use so-called bioidentical hormones. And really, we'd have to say, why would we do this? There is no safety data. We don't know that they work. There is no regulation as to the constituents, the dose, the quality, or the sterility. And in fact, there were 64 women in the States who died after having been given bioidentical hormones for one or other various indication. You need to be very careful if you are writing the prescription, and of course, for these hormones to be given to a woman, there has to be a prescription from a registered medical practitioner. So if you write the prescription, you need to be ready to take the medical legal consequences. And in fact, we've got numerous approved natural estrogen options we've discussed. We've got oral natural estrogen, we've got transdermal estrogen, and we have natural progesterone. And we know that they're pharmaceutical grade and that we know the safety data, we know the risks. Why would you, in fact, go down the bioidentical route? It just doesn't make sense to me. If you want to know a bit more about it in a bit more detail, in about 3 weeks, I'm talking at the South Island College meeting, and that's one of the topics. Now let's get on to Kathleen, who's 61, and she's on Cliovance. This is a very common referral. She's really happy on her hormones. She's basically a healthy woman. She's had no problems. And her doctor has said, all right, you're 60. You can't keep on the hormones. Now, and we're going to make you stop. And in fact, she knows when she skips her hormones or she's tried to wean off in the past, she gets terrible hot flushes. She's really upset, but that's the advice she's been given. And the concept of this has arisen, and I'm not really quite sure why it's arisen, that there's an arbitrary age that people have to stop and there's an arbitrary duration of time that people can be on hormones. So that's Kathleen's case. Now, there are several statements that you can refer to if you want to look at a professional body. So North American Menopause Society say that basically this is something you decide individually with the woman and depending on her health risks. So use her as her own bioassay. Individualize it. Don't stop just simply because she's reached an arbitrary age or she's been on it for an arbitrary length of time. You might consider trying to make the hormone dose lower. You might consider that you might, if she's on an oral estrogen, you might then try and move it to a so-called gold standard estrogen. So you might give her a patch. You might say, what about using natural progesterone as opposed to synthetic progesterone? So you could have conversations around that. But just because she's been on it 8 years and just because she's 60, if she's still got the indication to be on it, you don't have to just take away her lifeline. I think that will definitely make you popular, even if you've lost popularity with not giving the bioidentical prescription. And very similar for IMS. Don't prescribe it if you haven't got an indication. It doesn't need to go in the water supply. Make sure you keep an eye on women, an annual medical consultation, but again, as stated, no mandatory limits on duration or when exactly someone needs to stop. Now, when might you actually refer a patient? And as I've said, premature menopause, I think definitely. Someone who's into their 60s and perhaps has put up with their symptoms, maybe had a late menopause or just has been, tolerating the symptoms all these years and is absolutely over it, wants to start. Someone who wants to keep going, well into their 60s or who's developed some complex medical issues or, perhaps has them and you're feeling a bit uncomfortable. Persistent breakthrough bleeding you can't control or persistent menopause symptoms, and perhaps someone who you just can't get settled on your own, regime of simple MHT regimes. You might want to refer. Now, I think we could just sum up at this point and say that just remind you of several things. Menopause is a clinical diagnosis, so people are going to stop doing FSH measurements or estrogen measurements in general, and you're certainly not going to use them as guideline to management. Use the menopause consultation as an opportunity to really optimize your woman's health, bearing in mind that she might present to you at 45 or 50 and her mean life expectancy might be well into the 80s. Remember what we're trying to treat, that we're relieving menopausal symptoms, particularly the vasomotor symptoms, but mood, the genitourinary symptoms, the sleep disturbance are also going to benefit. And of course, the woman who's also got low bone density or who's fractured, this might be a very reasonable option to consider. And if you've got women in the group that we're generally considering treating, so under 60, within 10 years of the menopause, when they present with their symptoms, the treatment of choice is menopausal hormones. It's important to offer a woman an evidence-based approach. Use the dose that will control her symptoms, keep an eye on her with an annual review, and you can reassure the woman who's healthy and who's got significant symptoms, that the absolute risk of complications is in fact very low in this setting. We've briefly touched on, and just to remind you that you can alter that risk-benefit ratio even further if you alter the dose, you alter the route of estrogen. So transdermal therapy has less risks than oral therapy. If the woman doesn't have a uterus and you don't need to use a progestin, then you've got even less risks, particularly reassuring around the breast. And remember that not all progestins are created equal. And I guess Joanne Manson has summed this up really well. I think this is probably the worst thing that has happened to women's health is the WHI publication and the hysteria and the misinformation that has arisen from that study. But that is now 16 years ago. So I want to remind you that we've got options, we've got evidence-based options, both menopausal hormones and other options to treat women effectively. They don't need to endure symptoms that seriously affect their quality of life, and you can be extremely reassuring for the great majority of women that the benefits significantly outweigh any very minor risks. I think we really can put menopause management back on track, and I'm hoping that after tonight I'm just about doing myself out of a job. So thank you very much for your attention.
Look, Stella, that's been fantastic. It was an amazing presentation. It's covered a lot of the questions I think that have come through, but we also still have a bunch, so we've got a bit of time to get through them.
Yes.
First of all, someone just asked, when we do refer, thank you for the slide on referring, if we do need to refer someone, are we looking at referring public through the hospitals or privately, or either an option?
Yes, I mean, I guess the audience is all around New Zealand, isn't it?
Yes, right.
Yes. So certainly in Auckland, I mean, I have a DHB, I actually have a tertiary clinic at National Women's Health, and I mean, you can address a referral to me if you've got difficult menopause to manage. I think in the other DHBs, this will be managed either by endocrinology or possibly by the Women's Health Department. Smaller DHBs, it's probably done in the Department of O&G, and I think most people are also doing it in the private sector, but it certainly should be able to get assistance in the public sector.
Fantastic. Now, I've had a question about otosclerosis. So is MHT able to be prescribed for someone who has ear issues? This is a particular case that this person has asked about, who has is deaf in one ear, has a problem with one ear, and obviously has concerns about the other ear and it being prescribed.
Sure. I mean, that would be extremely uncommon, and I think what I'd probably do in that setting, I've got a couple of patients in that setting, and I guess the concern is there any accumulation of fluid with estrogen particularly, but perhaps with the progestin that could worsen. I think the chances of that happening is extremely low, but I think the reasonable thing to do, of course, this is a very important issue for a woman if she's already lost hearing in one ear, would be discuss it with the ENT surgeon and the woman, but there is no data that I'm aware of that says it's a contraindication.
Okay. There's been quite a few questions here, which I'm going to try and encompass in one, which is about the BMI. So obviously, a lot of our cases here were slim European women.
Yes.
Often we see
comment. Yes.
Often we see people who have medium to higher BMIs, who are from different cultural backgrounds, and we would like some comment. I think various people have come in sort of saying, you know, how on different BMIs and they've different risks depending on what race you are.
No, and I think that's a really good point. So BMI is not a contraindication. So it's not like synthetic estrogen and the birth control pill. A couple of comments. The higher the BMI, often the worse the symptoms. So it is interesting, and the greater the breast cancer risk. So I'm always a little bit bemused by the women who are sedentary and heavy and drinking a glass or two of wine at night, who are very worried about breast cancer risk with menopausal hormones and completely unworried about their lifestyle choices. So in general, here's a wonderful opportunity to encourage this woman to adopt a slightly more heart-friendly lifestyle. But of course she can have hormones if she needs it. You might opt in that setting perhaps to preferentially use transdermal estrogen just because she's a woman who's got higher vascular risk and higher blood clot risk per se.
There's been,
one more comment is, of course, that is a woman who's also at increased risk of endometrial hyperplasia, endometrial cancer. So again, don't make sure she's adequately covered with a progestin.
So it's just thinking around those factors more. There has been a question about what role does Tibolone or Libido have, please?
Oh, good. I didn't put a Tibolone slide in, I thought, in the interest of time. Now, the problem with Tibolone in New Zealand is we've never had it funded, and it costs quite a lot of money. It's in the order of, I think, about $120 for 3 months supply, maybe even more, depending on your pharmacy. So it's available, but a reasonably costly option. Essentially, it's got the same risks and probably the same benefits as do conventional estrogen plus progesterone menopausal hormones. Tibolone's got is basically estrogenic, progestogenic, and has got a little bit of an androgenic component. So the woman that it might be a little bit more helpful for and might consider paying for it is a woman who's got a libido issue and who hasn't responded to more conventional regimes. But I think we have to assume the same blood clot risk. There is a small stroke risk with older women, and interestingly also potentially a risk of breast cancer recurrence in the women who've had a previous breast cancer. So it's exactly the same category. So there's not a big group of women. In fact, there's probably very few women that Tibolone is going to be your go-to MHT. Hope that answers that question.
There's also been a question about Duaviv.
Duaviv, yeah. Now, Duaviv, it was registered in New Zealand last year. I don't believe it'll ever be funded. So again, a moderately expensive option, about $60 a month. So for instance, the women using natural progesterone, the women using the all-in-one regime, something like Clivance or Trisequence, they're paying around about $30, $35 a month. So Duaviv's another step up. Duaviv is a fixed dose of a conjugated estrogen. Now, remember, I've said we now have funded natural estrogen, beta estradiol, either orally or in a patch. So one of the problems, I guess, with Duaviv is that we've gone back a step. When it was prepared, they used conjugated estrogen, which is what was in the WHI trials. That's, of course, is derived from equine urine. And it's a relatively small dose of estrogen. It's only 0.45 milligrams. So again, you don't have the ability to alter the dose of estrogen depending on a woman's symptoms and titrate up. What the appeal of Duaviv is that it's matched with a SERM, a selective estrogen receptor modulator, which is not a progesterone but does protect the endometrium. Now, the problem is we don't have clinical data that tells us what this does to breast cancer risk. So we have some animal data. We know that the Duaviv combination, which is just one tablet a day, is safe in terms of the endometrium, and it's probably as effective as about half to 1 milligram of estrogen regime together with a progestin for hot flushes. We do not have data to say it has reduced breast cancer risk. We're hopeful. It's certainly a possibility, but we're only 2 years in terms of the clinical trials, and I think that data won't be available for a while. So you're asking someone to pay $60-odd a month for a tablet when you could, if you want to keep breast cancer risk to a minimum, possibly not even any increase, you would be using you'd be using a transdermal patch of beta estradiol and natural progesterone capsules. And you'd be doing it for half the price. So that's where I would go as we stand in 2018 and watch the space.
There's been a few questions about the length of time of MHT, which I think you answered
Yes.
in one of those cases quite well. One particular question is, how many years can the Mirena be effective as part of the MHT?
Yeah, another good. These are really great questions, guys. Thank you. So I just generally consider that the Mirena is effective for 5 years, or would change it a bit sooner if a woman's getting bleeding, having been amenorrheic. So in some women, the Mirena doesn't quite do the 5 years. And so if for the 4-year mark, they're starting to get some breakthrough bleeding, I would generally get the Mirena changed at that point. Otherwise, the 5-year mark.
Transdermal progesterone recommended by pharmacists considered bioidentical hormones, and if there's no evidence for them, is it still safe to prescribe them if patients are requesting them?
I think it depends the indication it's being prescribed for. So there is, as I said, zero data that it is I shouldn't say zero data. There is minimal data that it is effective for hot flushes. So if you want to prescribe bioidentical progesterone, which isn't inexpensive, for a woman who's got hot flushes, I doubt you're going to do her much harm. But nor are you offering her a particular, either a useful or an evidence-based treatment. So I'm not sure why you would do that. Mm-hmm. If you are using it as part of a menopausal hormone regime therapy, then it's completely useless. And the reason for that is that it doesn't get systemically absorbed. So it doesn't do what it's required to do and protect the endometrium. So remember, whether you're using it in someone who's getting conventional bioidentical, we should say body identical hormones, which would be estradiol tablet or an estradiol patch, but also a woman who's getting bioidentical estrogen via a troche or a cream or whatever, that is extremely active estrogen. Estrogen is well absorbed through the buccal mucosa, through the skin, whatever. So it's incredibly active and can sometimes be very high dose because it's so unregulated. So it would be completely inappropriate if woman has a uterus and the progestin component was progesterone cream. I hope I've explained that. So, and I would, it seems to me in clinical practice that most people who are using the so-called bioidenticals have understood this and have moved to the capsules of progesterone.
The next question is about hypertension, and there are two parts to this one. Someone's asked if hypertensive medications seem to make hot flushes worse, or is there any evidence behind them making them worse?
Not usually, no.
Okay.
No.
And the other question was, do antihistamines, are they an option for management of hot flushes?
There's a tiny bit of data, but again, why would you go down that track when you've got a number of other evidence-based options where you know basically the equation between benefit and risk?
The efficacy is higher.
Yeah, and the risk is smaller, and you know that. So you've got a lot of choices before you're getting down to something like an antihistamine. I mean, I didn't mention, again, with the interest of times, I mean, there are some uncommon things that are trialed, such as antihistamines. There is a procedure called a stellate ganglion block, where you actually block the sympathetic nerve supply, and that's done by the radiologist in Christchurch. That's got a sort of small role, perhaps, in the woman in her getting into her 70s who's still got miserable symptoms and perhaps has got other vascular risk, and you're trying to avoid hormones, but you need to manage the symptoms.
Thank you. I think that adequately answers that. Mm-hmm. The next one is if someone needs high dose HRT to control symptoms, are you happy to continue along on that high dose, or do you look to try and reduce the dose as time goes on?
What I generally discuss with my patients, and I think it's very much a matter of trying to do it as a joint deal with the patient. I think if women understand what you're trying to do, then you get better buy-in. So I treat to 80 to 90% rather than 150%, trying to keep that balance of benefit versus risk or side effects. So it depends what we call high dose. So high dose oral estrogen would be, say, 2 milligrams of Proganova or Estrofem. High dose patch would be 100 micrograms. And many women will have their symptoms essentially gone, and often gone within, I say to women, maybe allow 3 to 4 weeks, but often it's gone within days on a much smaller dose than that. So there are some, for instance, other countries have some very small, have some very low dose regimes, which are often very successful. If you've got a younger woman and she's needing a bigger dose, and certainly some of the premature menopause or surgical menopause may be at that higher end of the spectrum, yes, I think as time goes on, particularly if the woman has tried to perhaps wean off and got recurrent symptoms, and it's clear that she's going to continue on for a while longer, you might look at dialing back the dose at that point. But again, remember, our treatment goals are to put her quality of life back on track. So, making someone absolutely wretched with vasomotor symptoms simply because you want to be on 0.5 milligram rather than 1 milligram of medication would be, I think, pointless and cruel.
So then we have another question about the shifting from sequential to continuous MHT. When do we shift?
Yes. Yeah. Well, generally what I do is, as I said, if a woman's been having periods or her last menstrual period was within 12 months, it's too hard generally to try and make them amenorrheic. So I give them a cyclical regime. Generally, people are very happy. They continue on that for a while. It might depend on the woman's age, and there might be cultural issues or her expectations around periods. Most of my patients are actually pretty happy to have a light regulated period that they know when to expect for a few years. And so often it's me suggesting that maybe we'll move them to a continuous regime rather than the woman, but certainly bring it up any time after a year or so on a cyclical regime. And it depends a little bit how you get on when you try to make that change. I think most women would prefer to know when their period's coming than to have unscheduled bleeding.
Yes, I think that makes sense. Does the higher doses of estradiol need a higher dose of progesterone for endometrial protection?
Yes, it does. Yeah. And look, I think that a really good table is on the Australian Menopause site, and it tells you what it divides it into is low, medium, and high dose estrogen, and then the appropriate progesterone regime. So that's probably easier than me going. And as I say, in the interest of time, I showed you some regimes, but there are many options. But yes.
Fantastic. I'm just going through. We've had so many questions come in tonight. It's been a fantastic webinar. I think we've answered most of them. Is there a risk for a woman with fibroids having MHT?
We wouldn't consider it a contraindication. If the fibroid is submucosal, so it's abutting the endometrium, in that setting, you might then find that you've got some bleeding issues, and in which case you might involve a gynecologist. So I think that if you know you've got a fibroid uterus, you'd probably, again, just discuss with the woman and basically try it and see what happened. Most women with fibroids would be fine. They're not going to grow with the hormones, but the odd woman, especially one that's submucosal or a particularly large one, it might be an issue that requires a little bit more creative thinking. I mean, quite honestly, I've even got patients, and this seems extreme, certainly wasn't my suggestion, but I've got patients who have actually had a hysterectomy so that they can stay on estrogen.
Wow.
Yeah, that's I think I couldn't put it more clearly, the difference it's made in their life. So that's why it's terribly important that women have a voice again. Yes. I think we've done women an enormous disservice over the last 15 years by not registering these symptoms, not treating them as significant, and particularly not offering them useful management choices.
Yeah, absolutely. Look, this has been fantastic. There's been a few questions about being able to get a copy of the slides. So these slides and all the audio of Stella tonight, so all the discussion will be on our website, along with any resources that are useful from Stella. I think we'll put that Australian Menopause Society. Hang on, I'll click over. There we go. Yes. And we'll make sure that everything's up there for you, so you can go back through in your own time. There we go. So all of this will be up on the website afterwards. And Stella, look, I think it's created some amazing discussion. Hopefully it's given primary caregivers more confidence about what is.
I do hope so.
Yeah, that's right. And I think some of this is getting used to prescribing again and knowing that evidence again, as you say, upgrading our knowledge around that. And I'm sure that if anyone has further questions, we can go through and see if there's anything we've missed tonight and follow up with that down the track.
Absolutely, yes. And thank you everyone for taking the time to listen in.
It's been fantastic. Thank you. Good night, everyone.